My name is Romain Bach. I studied political science and public administration. I work with addiction policy for about 8 years, and I am now the co-director of the GREA, Groupement Roman d'études des addictions, which is the association of the addiction professionals in the western part of Switzerland, the French-speaking part of Switzerland. That's why I have this French accent, so please excuse me for this. I'll try to articulate as best as I can. I would like to start with you, Thilo Beck. You studied law before you decided to switch to medicines. You have worked in different academic psychiatric clinics in Switzerland, both in and outpatient settings, and you are the lead psychiatrist in the specialized center Arud, based in Zurich. Besides continuing education in systemic psychotherapy, you also specialize in addiction medicines. You are a member of the board of the Swiss Society of Addiction Medicines and a member of the committee of the Fachverband Sucht, which is the association of the professionals of addiction of the German-speaking part of Switzerland. You have been the investigator of a wide range of studies, co-author of many, and we will discuss together one of the studies that came out of your work in Arud. Before starting to talk more in depth about addiction, I would like to ask you first, why do you work in this field? Why are you interested in addictions? And what keep you going every day at work these days?
That's a very good question. I could talk about this for hours. Many colleagues of mine ask me why I'm still working in this field now since 25 years, I think. And then I always tell them that this is such a fulfilling type of work I can do here, because there is so much to be done still, and there are so many challenges, and I've always been busy trying to improve the situation for the patients, for the people with addiction problems, to improve their situation, to help them, to support them. And I came to the realization that it's not only about the treatment of those people, because what makes them actually, what's a big factor that makes them sick actually, or makes problems for them, is the political situation. And so I ended up being a psychiatrist and a clinician, but also an advocate for and trying to change the political situation, because I think as long as we have the situation as it is now, we are treating the damage that the politics create. And this is, in a clinical view, just terrible. So that's why I'm still working and trying to improve the political and the situation, and the situation for our patients.
Thanks a lot. Barbara Brues, you are professor of addiction medicines, working in a primary care medicine division in the Geneva University Hospital. You are a member of the Federal Commission on Addiction and Non-Transmissible Disease, among many other things. You're also a member of the committee of the GREA. You are a renowned voice for a human rights-based approach to drug policy, treatment, and harm reductions. I'd like to ask you the same question as I did to Thilo. What interests you in this field, and what do you think are the main topics you should address these days?
Thank you for the question. It's partly the same as Thilo. For me, it's really a coincidence I'm in this field. I never thought I would be working in this field. I was a medical student, and during my studies, I did a clerkship with a GP in Amsterdam, in the center of Amsterdam. It was in the 1986, and then suddenly she said, "Can you maybe replace me next week, giving information on HIV for a drug users union?" So that was the junkie bond in Amsterdam. So, and I'd never been working with people who use drugs. I'd never, AIDS was something very new. We had the 2 pages of what it was. So I said, yes, why not? And I started doing that. And it was so interesting. So I continued during that time. I was still in the Netherlands. And then I came in Switzerland, and there was a job in the Geneva University Hospital about people using drugs with HIV. And then they took me because I was, they thought I was a specialist, which I wasn't, absolutely not. But, and then of course, if you're in it, it's so fascinating. I have really always enjoyed my work so much because it's as Thilo said, there's everything, there's so much to do. So I started in 1990, and it was really the beginning of everything, which was introduction of agonist treatment, introduction of harm reduction measures. And since I came from Holland, I mean, I had contacts and we could exchange a lot. It was nice. And then I was really lucky. I worked with Annie Minot in Geneva, and she was really a psychiatrist, and really realizing the importance of the whole political side, the social side, the need to reform drug policy in Geneva. So she has been taking me everywhere to talk to the politicians, to work on different sides, and then, well, when you're in it, it's fascinating. It changes all the time. You have new challenges. And the challenges now are maybe different than 30 years ago, but overall they're still the same. You know, we all already talked about the importance of better regulation of drugs, of the need for harm reduction, of the problems with the war on drugs, with the problems that it's also the similar populations always that have the most harmful consequences of be it any crisis. Let's say that. So I think the challenges are still the same. The fundamentals haven't changed, and that's our main challenge.
Thank you. Karl Arud, you're a neuroscientist and psychologist. You're working as a professor of psychology at Columbia University in New York. You are also a clear advocate of drug decriminalization. And you wrote a lot of scientific articles, but also 2 books for the general public, High Price and Drug Use for Grown-Up. And also, what brings you to work in this field? How did you start this work?
I have to correct something.
Yeah.
I'm not an advocate for drug decriminalization. Okay. I'm an advocate for drug legal regulation. Yes. So my view changes based on the evidence. That's okay. It's not your fault. You did a really good job of understanding who I am. So thank you. What brought me to this field? I thought, like Thilo and Barbara has said, you know, people who are having problems with drugs, they needed advocates, skillful people to help. And so I came to the field trying to develop treatments that help people who have drug-related problems. But in the process, I got an education, a broader education, and I understand, just like my colleagues, that this isn't only about drugs. This is about politics. This is about bad policies. This is about marginalized people, a wide range of issues. I thought it was simply about drugs. And so it raises the questions now, why aren't we politicians? We'll have that discussion. Why didn't we go into politics? And I'm looking forward to hearing what they have to say about it. And so as a result of getting in education, I'm trying to apply that education more broadly, not only to drugs, but just in regards to our society, in terms of who are we? We claim to take care of people. We claim to make sure people have liberty. And all of these issues become critically important when we think about people who are having problems with drugs, or people who are just using drugs, or people who are new to a society, immigrants, people who don't look like folks in the general population. I mean, so all of these issues, they converge. And so I'm looking forward to having this discussion to see what people have to say about it.
Thank you very much, and thank you for correcting me about the terms. I have now Frank at the other side of the round table. Frank Zobel studied social science and public health. After working at the European Monitoring Center for Drugs and Drug Addiction in Lisbon as a policy analyst, he became a deputy director at Addiction Suisse, which is a national center on addiction resources that works on prevention, research, but also share its knowledge with the general public. And during the pandemic, you also tried to really analyze in the best way possible the drug market during the crisis. And I would like to thank you for sharing the knowledge with us today as well. Why did you start working in this field, or did you take interest into these questions?
Actually, I am going to repeat quite a few things that I already heard. Actually, like Barbara, I started by chance. Actually, I came back from my studies in Canada. I was completely broke and I was offered a job. And the job was evaluating the Swiss drug policy. Okay. And I think they hired me because I was speaking both French and German. So that's how it started. And then I got hooked. I mean, I got hooked because there are so many issues, the one you just mentioned. But also because it's plain wrong, because drug policy is plain wrong and you want to change it. And there's all these moral values around that you want to change. And so that became a kind of a lifetime endeavor, something I wanted to do through research in my case. And now I'm getting to the stage where I'm getting a bit tired of it, where I have the feeling I do the same things than 25 years ago. I read documents I wrote where I said, but I wrote it already 25 years ago. But so that was the story which brought me into this field. And it's still interesting. There are still some aspects of it which I discover and which are interesting.
Thanks a lot. Now we will start to have a more broad conversation about a few topics. I have a few questions for every one of you to start the conversation, but if you want to say anything, don't hesitate. I'll give you the word. I'd like to start with a question for you, Thilo. A study came out with data from the Arud Center in Zurich. The study is called High SARS-CoV-2 Seroprevalence but No Severe Course of COVID-19 Disease Among People on Opioid Agonist Treatment in Zurich, a cross-sectional study. So if I'm reading this study correctly, what it shows is that many more people within the sample that you studies became in interaction with COVID because they show signs of antibodies. How do you but the disease was not manifesting itself with strong symptoms. How do you analyze these studies, and what do you take from it?
Well, that was a big surprise to us when we read the results of our study, because we didn't see any severe outbreaks of COVID in our treatment population. Hardly anybody. We had one of our 1,500 patients or clients in ORT treatment hospitalized, and nobody died. So that was a very big surprise to us. We thought they were vulnerable and they might suffer severely from COVID. And when we then saw the results of the antibody screens, they had triple the prevalence of, they had been infected with COVID, but they didn't have any symptoms. So that was a big relief then as well, to see that the people we treat are coped quite well with COVID. And the question why this was the case, that they have so much more seroprevalence, that so much more of them had been infected with COVID compared to the general population. We really don't know. We think they are might be a very close community. They stay amongst each other. So maybe the the virus spread easier amongst the people we treated, and and why didn't they get more severely ill? We think it's a cross immunity, that the way they live, that they have been exposed to many viral infections over the years, and that they might have picked up immunity that protects them from the coronavirus as well. So altogether, I think it's very positive result of our study to see that they came through this quite well.
Theo, may I ask a question? In terms of their physical conditioning and shape, were they outside? Do they exercise more? Were they moving? Or
they are in a worse medical state than the general population. That was clear. Yeah. And still, they were not as affected. Yeah. There is lots of comorbidities that the people we treat have. As a result of the lifestyle they had to lead, and because of the criminalization and the illegal status of the substance they use, and so they are in a much worse state than general population.
So the paradox was that they were seen as an at-risk population, but they weren't, in fact.
Yeah, in fact, they got through it better than the general population.
So there might be something that's protective, but we just don't understand. Well, Barbara, please.
Yeah, well, first I would like to say that I think the model of care in Arud is a model I really think is an excellent model of interdisciplinary care. So in a way, the people you have, they're the worst, maybe they have bad conditions, but they also have a good care system. So I think that's maybe a sort of bias. It's not the people in the street, because they are with you. So I think it's important to say that I think it's fantastic that you do the work you do as an NGO, and then also publish things, which make you think about a lot of things. So I would like to give you the compliment for that, and say that I think it's very important. Maybe to add, we had the same observation. It's not published, but the same observation in Geneva. It was quite astonishing. Nor in the safe use facilities, nor in our agonist treatment and heroin prescription programs, we saw a huge epidemic and death. And we were sort of, where are they? Where are the patients? They're not in the hospital. They're not. We don't see a huge epidemic, even among the personnel, not either. So that was an interesting observation, and we can hypothesize about this cross immunity. Maybe it's something else. We don't know, but it's good to know. But I think there's another issue here, is that this was the first wave, and the first wave, we didn't see anything, that. But then this thing lasted longer. And I think we should do the study again now, and with the second wave, because we have seen, after 1 year, we had really an increase in hospitalizations in the hospital with people, mostly with alcohol-related problems, and but people with not so much with or agonist treatment. But we saw really then there was that this difference that we thought has gone fully. The hospital was full with people who used alcohol, illegal drugs, and so on. And then might be that there's a sort of leveling off, because there's more poverty, the people were more stressed, they're more alone, they lost their jobs, and so on. So maybe this relative advantage of the first wave has gone. So maybe you could do a second study now.
Yeah, I mean, as far as we can tell from our clinical point of view, we haven't seen any, the mortality has been very low continuously after the second wave as well. We haven't seen more people dying than before. So every data we have tells us that
within
it's
your
a
program.
stable situation. Right?
So, Thilo, what about this issue that Barbara raised about care, being that they're receiving excellent care? Well, what do you think of that issue?
Well, on the other hand, during COVID, we had less contact with our the people we treat, and because they had more take-homes, and we stretched it to the limits, really. And so there was less contact, and still.
But you called them, but you were in contact in a way.
Okay, and we had less. We made an analysis of our interventions during that time, and we had less antibiotic treatments. We had less interventions for medical reasons. Yeah. So it was a more stable situation than before.
Okay.
That's surprising, right?
Yeah.
I'd like to ask you both, Barbara and Thilo, a question about maybe the socio-economic state that people live during this pandemic. Did they live in a state of uncertainty about the future, or was it already the case before? Did it change a little bit? Did you experience any change in this regard?
Well, maybe I can start. When I looked at our population, I take care of a mixed population of people who use substances, also elderly who have alcohol problems. And I think that was the most difficult population, because they would like to come to our unit to have a consultation. It was like their outing. They don't have very often other relations outside the medical world, which is really the reality of people. And then we were not allowed to do any more medical consultations, so we had to call them and things like that. So that was really difficult for many people who have this, regular medical visit, which is one of their occupations. And of course, pubs were closed, so there was a lot of loneliness, people, and that was, that was dramatic for many people. In the beginning, people were so scared, I think, of the virus, that they felt safe at home.
Yeah.
And drank less. But then again, then everything opened again, and then the second wave, there was so much depression and solitude and anxiety. Oh, not again, this horrible period, and so on. So that's one thing. I think there is the people who were alone and who had difficult situations, also people living in the street. Well, there was a paradox, because people living in the street, finally there was a system that people got a housing where they could stay 24 hours per day during a time. Where usually they go to shelters, they have to leave at 7 or 8 in the morning and can come back, so they have to go around in the street all the time. So it was a paradox in the beginning that people had better housings because suddenly they were allowed to stay, and so they were not on the street anymore and wandering around and not being able to go in a restaurant and so on. So that was a good solution, and we saw the impact for people who were using less drugs because we're not out in the street all the time. But again, then the second time that was different. Then I think there was, what I found was incredible, was the response of all the services we have. That they were so inventive and proactive in trying to remain in contact with people, going out and calling them and going home to people to the needle exchange and all kinds of things that never existed, to remain in contact with people who were in difficulties. And I found that fantastic. I mean, there was something I really enjoyed, I have to say, in this whole period of sort of, wow, the energy we got from all the professionals trying to do as well as we can to improve the situations of our clients and patients and remaining in contact with them and being very innovative, doing things that we never could do before. And also what was important then was the fact that we had all this coordination that pre-existed between all the professionals in the field, like through the GREA, for instance. You have the platforms. So, there were very many practical questions, how do you disinfect things and how do you get your mask? And there was so much exchange between people, which really facilitated that, you're not trying something to do on your own. You could call people, you knew people about the platforms. So I think that helped not to have people, disappear, fully. And I think we didn't lose many clients and patients in that period, which I think was very positive.
Well, I was quite surprised to see that the people we have in treatment with opiate dependence, I don't think that they had such a difficult time during COVID, because they have had a difficult time before already.
Yeah, yeah.
So they are used to have a marginalized life and to be sort of outside of the society. And so that didn't change that much for them. And they were really grateful for the take homes we got. That was thanks to Corona. I think that was one of the greatest steps forward in Swiss policy, drug policy.
Have you stayed with that policy?
Yeah, we are working on it now in the head to keep the 7-day take homes. Because that was a great improvement for them. We made some surveys with our patients, and they rated the 7-day take-homes 9 out of 10, considering their lives quality of life. We got feedbacks. I never was that well before, and now I have time to have a regular life. I don't have to come to the facility every 2 or 3 days. And I can share time with my family. I can do hobbies, and it was a new life to them. So it was an improvement.
But you knew this. You knew this was the case before, right? You knew that if patients had take homes, they would have these kind of improvements. So did you advocate for this position before, or what happened when you advocated for this position before?
Well, we are fighting hard for normalization of HAD, especially heroin-assisted treatment, because I think from a medical point of view, it's just not right to have these restrictions on a medical treatment. There is no logical reason for it, and people suffer from it, and we keep people in a dependent state in treatment, and we don't let them live an autonomic life. And I think this is just wrong.
You know, every time I talk to you and Barbara, you guys, I always learn something new. So I didn't know this. And so now I have a new piece of data, new piece of information to go back home with. So thank you again for that new piece of information.
Yeah. So I wouldn't say that they enjoyed the Corona pandemic, our patients, but I think they came through it much better than we expected, and their quality of life hasn't gotten that much worse than it was before.
During the first wave, we have interviewed a set of patients from the Lausanne OAT clinic, and it was interesting. Some found the situation really difficult, but there were quite many who found it a very positive situation. There were 3 things coming out. The first one was there was more solidarity with them. Yeah. There were more people helping them, not professionals, people. The second was they had a break from the drug scene, and they were very happy about that, get out of the stress of the drug scene. And the third was that the professionals were very caring during that period.
What do you mean a break from the drug scene?
Because the drug scene where you buy the drugs, where you exchange is a very stressful situation. And you go into that every day. And because of this situation, because nobody was in the streets, except the police, so you didn't have your usual drug scene. You were still getting your drugs, but so you didn't have this being the whole day under stress. Right. With people around you,
So it became easier.
It became easier. You were doing your drugs at home. You were doing it. It was simpler. That's what they reported.
Right. Yeah, I just wanted to be clear, because some people might think that when you said break from the drug scene, that they stopped taking drugs. No, that's not.
No, they were continuing taking
They got
drugs.
a break from the sort of
violence,
the psychosocial things that we put on the scene because of policy. I understand.
But also the interaction in the field, which sometimes stressful.
Sure.
That's an interesting difference between the French part and in Zurich, for example, because in Zurich the drug deal it takes place in consumption rooms, and it's accepted by the police, and and that continued. The consumption rooms were open. They even improved the treatment services, and so that was continuously going on, and there was no shortage or
But that we wouldn't call that a drug scene. Because it's not the stress, it's normalized drug trafficking.
It's assisted drug dealing.
Yes. which is not allowed in Lausanne in Geneva.
But one of the things that Florian Mayer from Zurich told us, who is responsible for the drug consumption rooms, because they had to close the drug consumption rooms because of safety measures, of health measures. But what they did is they went to an open place, which is the place where there's the prostitution in Zurich, and where you have this little garage where, and they had a very big drug consumption rooms outside with much more space. And he said the stress around the drug consumption room reduced massively during that period. You know, the kind of, you know, how you have sometimes in drug consumption rooms where there are many people and there's stress situation and, you know, is it my turn, not my turn? And so it was much more relaxed during the COVID period because they had this huge space, because people could go, you know. So it was interesting. And it was very interesting how Zurich reacted very rapidly to the situation and found a very practical solution. You know, in Bern, I think they brought containers because they didn't have the space anymore. So they brought containers, you know, these big things to have more space for the drug consumption room. So people, as you said, the crisis, people become creative. You know, crisis is good. Huh? In crisis, you change things.
Yes. Crisis can be good. It can also be bad.
Can be the occasion for change.
One aspect of the crisis is that it brings opportunities to think maybe outside the box, to bring new policies to the room without having the same condition as before. Maybe you can go forward a little more, and you bring a lot of examples forward. And I hope this example will continue in the future, and that we follow this road and maybe be more innovative. Karl, I'd like to have.
Can I say a word just
yes,
on the crisis issue? We're probably going to talk afterwards about this opioid crisis in the US. But you see that the same phenomenon in the US and in Canada brings completely different results. In Canada, they have just opened a drug consumption room a month in recent years. So I don't know, they went from 1 in Vancouver into 30, I think they have, or 40 now. They have improved access to medication, to substitution treatments. They have done they have drug checking in drug consumption rooms to make sure that it's not fentanyl and so it's a completely different management of the crisis than what is happening in the US. So, you know, it's true. A crisis is not always good, but it can be good in some places. And we had the same in the 80s and 90s when the Swiss drug policy, you know, the crisis allowed to change the Swiss drug policy.
The crisis allowed for practical solutions to solve the problem. In the US, the crisis allows for the police to create more crisis. That's
it can also be
that can be like that, yes.
And that's what I would like to discuss a little more in depth with you, Karl. What about the drug situation in the US during the pandemic? What did you see? Did you see new phenomenon? You just talked about what the police did during this time. Maybe more crises arose. What would you say?
Yeah, so when we think about the U.S. and we think about drug crises, and particularly when we compare it to something like Switzerland. Switzerland is so small. What is it, 7 million, 8 million people? That's New York City, 8 million people. And so we have 330, 350 million. And so if we understand that, and then we also understand that the drug crises or the drug war, just drug regulation in the United States, is one of the largest jobs programs that we have. And so when you understand that the importance of that jobs program, like It employs a lot of people, people who do urine tests for drugs, police, people who work in the prison sort of agencies. You think about all the bad movies and films that are made about drugs. All of those people, they benefit the media, and they do these awful stories. So the sort of function of drug regulation and the drug war, it's slightly different. Here, your goal is to solve the problem. And there, our goal is to make sure that the jobs are still there. And so we aren't necessarily trying to prevent deaths. No, that's what we say, or we're not necessarily trying to save the people who are using or the people who may have a problem. I know that's not the sort of politically correct thing to say, but it's the reality. And I say that with, you have to have data to kind of back this up. If you look in the US and you see every year the number of people who die from what they call a drug-related death, it goes up. Right? And then then you say, okay, a practical solution would be, all right, let's find out how these people are dying. And then you'll get biological confirmation. You'll measure the level of drugs in people's system, and you try and determine whether or not that drug reached toxicity. That has never been done in the United States. In fact, the only thing we do when it comes to measuring whether or not a drug caused the death, we don't do that. We simply just determine whether or not a drug is in the person of the person who is deceased, the person who's died. Now, oftentimes they have multiple drugs in their system, and we don't know if or which drug caused the death. We never have done that. Today, the sort of conversation centers around fentanyl, drug contaminations. Fentanyl is a more potent opioid, more potent than heroin, more potent than morphine. Potency simply means that it takes less of the drug to produce an effect. That's all it means. It's a drug that is approved in the United States to treat pain. But if people don't know that they have a more potent drug, they may take too much and they may overdo it and die. Now, if we are worried about drug contamination, there's a simple solution. Legally regulate the market, and then that goes away. Or you can even have an intermediary step by having something like drug checking. Drug checking meaning that people can submit small samples of their drugs and have it tested for contaminants. Those are simple solutions. Check to make sure that the drug that you say caused the death actually did cause the death, one, or legally regulate and legally regulate the market, and implement drug checking. All of those things will address the issue related to drug-related death. None of those things have been done in the US. So when people say that the goal is to prevent death, it just does not comport with evidence. So I hope that's clear.
It's pretty clear.
Okay.
Like you said, the US is a big country. Maybe in some areas, some cities, some states, some new policies could be implemented during the last few years. Maybe because of a systemic change, you have new opportunities. Maybe because some people with new ideas.
Sure.
Some stuff. Do you have some example of stuff?
Thank you. And please interrupt and interject, because we are having a conversation. This is the new policies. The policy that people have been most comfortable with is ensuring that people have naloxone or Narcan. So this is an opioid antagonist blocker. You administer it, and it can reverse the effects of something like heroin or fentanyl. And so when someone has an overdose related to opioids, it can reverse the overdose. That's the one that they're most comfortable with. But that's after the effect, and it's consistent with this notion of people should not be using drugs. So and that's not very innovative. We've had naloxone available in the States since the 1960s. So that's not innovative. It's just that it's now more widely available. Other places like Portland or Oregon, the state of Oregon, they have decriminalized all drugs to try to take away the stigma associated with drug use. Oregon is a predominantly white state. And so states that are predominantly white, not all, have been typically more innovative, in part because they see people who use drugs as their brother, their sister, their son, their people. And so they're more willing to try these things. But places that are racially diverse, the police are the only sort of innovation. And the innovation is that you give your police naloxone. That's the innovation. That is the primary innovation in the States.
The thing about the naloxone treatment, to me, it's just an emergency measure, and it shouldn't replace the solution of the problem, which would be better treatment. I mean, yes. I'm always asked why we don't have naloxone here in Switzerland, why we don't have this, because in Germany it's also a big thing, and they try to spread naloxone all over the population. And I always say, well, here in Switzerland we have one of the best treatment systems, and about 95% of the people who use opioids in a severe or problematic way have been in treatment ever, and 75% are in treatment on a given day. So the coverage is good. And I think that's the reason why we don't need that much naloxone here, because most of the people at risk are in treatment. And I think that should be the answer to this.
It's quite funny because thank you for this what you say, because I realize that even we never discussed this issue together. It's like there's a Swiss culture. I would exactly give the same answer.
Yeah.
It's funny because it's like they always say, yeah, well, we don't have naloxone, we should have it. They say, no, we don't need it. If you have a good access to agonist treatment, if you have a problem, if you have access to information, if you have access to drug checking, you should not need it. Maybe you could think about it if people leave prison, okay? That you provide some naloxone, or people who have been in residential treatment, they really force themselves into abstinence because the family really wants them, and you as a caregiver think, well, this person might use it, and then be abstinent. But I think it's interesting because it's like a Swiss culture, and we share this, and I find it very interesting. How does it come that we have this sort of common culture in Switzerland? It's the same thing. If we had a meeting with the old people from the French-speaking part of Switzerland a few weeks ago. There were lots of workshops, and then if you talk with people working, in a residential setting somewhere far away in the Jura, or people from Geneva and from Lausanne, they share this sort of vision. And I really think that is something very important. And I can imagine that in the States, it's so different.
Yeah.
And it's such a big country. So
yeah.
That's apart from the side, the important, how we deal with naloxone, which I think we don't need, at least not for the moment, and maybe I hope never. That's a sort of general observation.
Yeah, your drug war is not a jobs program.
No.
Yeah.
Well, maybe of course we like our jobs, but it's not that we.
No, it's not a jobs program.
No,
I mean, you make sure people are employed in other. That jobs program is dependent upon people being subjugated and dependent upon people suffering. If you have a jobs program, you want to have a jobs program that is dependent upon sort of pro-social things, not that. No.
Yeah. Can I maybe just get back to the overdose? What you said, I thank you for, talking about this importance of having good data and that we too quickly believe, that's true. What we talk about overdose. Two things. I realized that we are all a little bit in the science field, and we had this belief that if we have sufficient science, this will provide data for good policies and our frustration. So I think that's, you know, sort of that's. I think we share this.
We started out that way,
we've been in
the field for 30 years, and we're not naive anymore, right?
But still, we need good data. So that's sort of like a paradox. And it's interesting, really interesting what you said about this. You know, how we look at overdose. And I maybe just to get back for Switzerland. I also think we do not have good data. Even if I know now the limits of, you know, how using data for policy change, I still think it's very important that I think we need better data on overdose in Switzerland, because this was really one of the, you know, the things we could sell when we were trying to sell the 4 pillars of drug policy. Is, you know, we saw this huge decrease in new infections with HIV and hepatitis C, the decrease in drug-related death over time after the 90s, and then suddenly, you know, it's like we don't talk about it anymore. And now, if you look, there has been a change in how we record overdose and over time. And now we looked it up. We have no more data since 2019. So if we want to talk about the impact of the COVID on the overdose, we don't have the data. So and also I have to say, I don't know what now is in someone who is registered as a drug-related death. I have no idea. Well, what in the cantons is the difference between cantons? Is there like a systematic way of documenting or not? I have no idea. And I think that's a sort of blind eye we have, and we could maybe think about that, you know, that's time to improve, because it's so much used now. You saw there's an article published last week in the Lancet saying huge increase in prescription of opioids in Switzerland in the last 10 years, and a huge increase in the number of calls to the toxic centrum. You know, those where there are requests about, you know, when people are intoxicated with opioids. Nothing about overdose, but it's like, again, this alarming thing, oh, take care, we are going the same way as the United States. Whereas I think, you know, okay, these data, maybe it's good that we prescribe more opiates. People are aging and people have more cancer. We should give people sufficient pain treatment. And also the other thing is that before that, we used a lot of methadone, which was not in this register, and people have been switching to long-acting opioids for maintenance treatment. So it's normal that we have an increase, because we have switched quite 30%, I think, of our people on that treatment.
Who's documenting the deaths here? Like the death certificate, who's qualified to fill out the death certificate in Switzerland?
It's the doctor,
It's the doctor.
It's the doctor who makes the, how you say that, who sees the disease, and he puts the reason for the disease, and in few cases you have the toxicological analysis, but it's in few cases. It's not systematic, so it's very much on the evaluation of the doctor who makes the death certificate. And
then the difference is what's called a natural death or an unnatural death. Every unnatural death goes to for an autopsy. So if we don't know, they should go, and then you have a full analysis of toxic medications and an analysis. So there's an autopsy if it's an unnatural death. So then it's the legal system, and if it's a natural death, it really depends upon the doctors. So even if people get an overdose, you know, in the street, and if they die in the street, it's an unnatural death, and then you will have the data. But if they were taken to the hospital, they die 3 days later in the intensive care, because, well, they saw no more brain activity and so on. There will be no investigation.
I see.
So it's not an opioid-related death. So
I see.
So, but of course, I mean, that's a systematic error that we should have all the time. So
in the U.S., the people who are primarily charged with filling in the death certificate are medical examiners, people who are physicians, and they have training in forensic pathology. Medical examiners and coroners. So the coroners have, the requirement for a coroner is basically a high school diploma, and you are elected as the coroner, and you have to be a registered voter. Exactly.
It's
and
another
so
training.
Those are the people who fill out most of the death certificates in the United States. And so as we know, they have a wide range of qualification, education, and so forth. And so there is a lack of consistency in terms of who's filling in the death certificates in the United States. These sort of things are never discussed when they have the big number, 100,000 people die from overdoses. Like, who are filling in those death certificates? People who are not qualified. But this is what happens in the U.S.
Okay.
Thanks a lot for this discussion about data. I think we should continue it a little bit further. Frank, you did study the pandemic from a data point of view. What methods did you use? What did you find out during your studies?
So maybe first, the data that are available to understand drug use are scarce. Generally what we have are general population surveys, targeted surveys among youth, nightlife attendees, this type, or regular drug users, and a few other indirect methods like police records, this type of thing. That's what we have to try to understand what is happening with drug use. There's a new method now that is available for a few years that is interesting, which is this wastewater analysis, which provides us with a view. It doesn't tell us something about prevalence, but it gives us volumes of drugs that are used in a given population, and it allows us to follow trends and to compare cities, this type of thing. So during the pandemic, we came into the pandemic in a very bad data situation. We had our last general population survey in 2017, so we had no recent data. We had a few statistics we could follow, but we had very little data. So what we did to try to understand a little bit what was happening was we tried to do a few targeted surveys, and we looked at this wastewater data to see if something was changing. And there we had the big surprise that not much changed. And that was the surprise, because the hypothesis we made when we saw that half of the world was starting these lockdowns, and not just us here, but countries along the drug routes, Colombia, Venezuela, Brazil, and then Netherlands, and or Iran on the route from Afghanistan, Iran, Turkey, and we thought, okay, now, this market will collapse, it will disappear, and we will have troubles, and people will be looking for drugs, and some will get into a safe situation, get into treatment, and others will, do whatever, something that might be dangerous. What we found is that the market didn't change at all. There were some irregularities in the market we saw. There was, for instance, in the French part of Switzerland, there was no more hashish for one time, because hashish comes from Morocco through Spain and France, and there was a big lockdown along this route, so it was a bit more complicated. But otherwise, the drugs still came, the drugs were still used. What we understand afterwards is that even with all these lockdowns, even with this pandemic, if the people were not traveling, the goods were in this globalized economy still traveling the same way as they did before. And as drugs travel with goods, they were still coming the way they came before. And the market was still working. So there were a few strange things happening in the market, but otherwise it was there. And one of the big surprises we found also with the wastewater data is that even ecstasy, which is the typical drug you would expect to drop when you close all the bars and the clubs, ecstasy was still used. So probably people were still partying quite a lot. So we still had the thing during the week it's low, in the weekend it goes up. So there was still, people didn't stop partying just because there was the lockdown. So, and otherwise we found that the drugs in the streets were still the same. So there were no big drops in purity levels, no big changes. So that just went on as before. So that's one of the lessons of this pandemic, is even with all these obstacles, the drugs come and they are there. So good luck to try to stop them. Even with something like this, if you don't stop them, with such a situation which is completely unusual, unexpected, the flow of drugs still continues. So you can imagine what you would need to stop them, you know.
So the message is, in terms of the war on drugs, drugs won.
Drugs won, and good luck with the war on drugs. You know, just you won't win the war on drugs.
We have all realized that, and that's the.
Yeah.
But I mean, sometimes, as you said, the frustrating thing that nobody believes us when we tell that to the politicians, and I always come up with this data, and then they say, "Well, I don't believe it, and there must be a way to get over this, and we will crush them on the markets." And this belief is so persistent, but there is no proof of it at all. And who suffers is the people you're working for, because they have bad quality or they don't know what they get. And yeah, that was another proof how resilient this market is, and you cannot prevent it.
Yeah.
And just before the pandemic, we did this drug market study in the Canton de Vaud, where we tried to look in depth at the size of the market using wastewater data, surveys, and everything. And I mean, the seizure of the police is 5% of the market, or is somewhere between 2 and 10% of the market. So the market works; it's there. It's, you know, the prices are in Switzerland lower than they have ever been. It's cheaper to buy drugs than to go to the cinema in Switzerland. The purity levels are higher than they have always been. So
with some drugs, Frank, not with heroin. That's one thing I never understood. Heroin is so bad quality here on the streets, and cocaine is very good quality. It's about 95% purity. Heroin is about 10%. We don't have a clue. It's the market, the people who run the markets who decide.
It's always been, heroin has always been very low.
That bad. Yeah.
But then we have some tradition. What we found, which might not explain everything that is happening in that country, is that the heroin market is in the hands of groups from a certain part of Europe, and they behave the same way for the last 20 years. Basically, the heroin comes from Afghanistan, has 50-60% purity level, what you can get, with brown heroin, and then they cut it with this mixture of caffeine and what's the other thing, paracetamol, which is mixed, which has already the color of brown heroin, and they mix it together the same way. And it's really a tradition. They do it like this for a long time, and it's, you know, and actually that gives us quite a stable and reliable heroin market. It's bad, it's bad,
but you know it's 10%. Yeah,
exactly. So it's.
Do you guys get any problems related to paracetamol? I mean, if people are taking too much paracetamol with their heroin.
As far as I know, there are other reasons why there's liver toxicity with people who use substances, mostly alcohol. But we've never seen. I mean, I don't think it's such a huge amount. I mean, you need to take 5 grams of paracetamol, you know, per day for a long time, and then you get toxicity. I don't think it's that amount. It's, but it's an issue. Paracetamol is I mean, it's not the worst, no? I mean,
Did you experience some other changes in the drug markets in America? Is there evidence about the change during this period, or are the conclusions mostly the same?
I don't know as much about the drug markets as Frank knows about the drug markets here, so I don't want to disseminate misinformation. I don't want to engage in dissemination of ignorance, and so otherwise we would be like politicians, and I don't want to do that.
That's one difference. Okay. I think this discussion maybe brings us on the topic of war on drugs and maybe some alternative to the war on drugs, maybe market regulation, the political sphere for decades now. But there have been no real changes these last years. There is right now a movement in the political sphere for changing the cannabis market. In America, there have been changes also in this cannabis market, in Canada, in the United States of America, and Uruguay as well. So is there now a new opportunity for change, and why did it not change in the last 20 years, according to you in Switzerland? I'm asking you the question altogether. I don't know who wants to start on this one.
But
I think one thing that I'm really, as you said before, I'm feeling like Sisyphus, sort of trying to push and push and push, and it really doesn't happen. One thing is in Switzerland that we are victim of the success of our treatment system and the 4-pillar policy, that we made the scene disappear, that people are not that much visibly suffering anymore. And so that took out a lot of the dynamics of the people are not prepared to go into change when there is no visible problem. So I think that's one thing I'm really concerned about here in Switzerland, that the problem is not visible. And with the opiate-dependent people at least, and then we have the other part of the population that does recreational use and that goes to risk every weekend when they use recreational use drugs, because they don't know what they buy, and but they are not visible either. So there's no open scene with them. So we have the problem that there is no visible problem, and that's another thing I'm thinking about a lot, and that we don't have people organizing themselves who use drugs. We have no drug user unions here in Switzerland who would make pressure. So, and I think we do advocate for change, but we don't have the people using on our side, and I think that's another problem.
But Theo, don't you think that there are people who are using, and they're not like a drug user union typically means that drug users who are having problems. But in your population, you have respected bourgeoisie people who use drugs, but they're silent. And they are also being subjected to some of the risk of getting tainted drug. So why not call those people to task and ask those people to join in this fight to make sure that somehow the market is free of adulterants by legally regulating or by doing something else? Why not put pressure on those people?
I think that's something about Switzerland, Swiss people. They don't like to expose themselves. And, I don't see any readiness to go that way with the people who use drugs.
Well, it's a paradox in the sense that Swiss people really talk about the importance of alcohol, the importance of the liberty, that you have to be able to choose what you use, and also for cigarettes, which is it's your own choice, and so you can say that, and so it's encouraged, and there's publicity, and there's no good regulation for that. And you can really open. It's important that you take a glass of wine, when you are official politician and stuff like that, with the opposite of, when it's forbidden, and you are a good Swiss, so you're not allowed to talk about it. And I think it's what you make up. I think we miss that. We miss that. People who dare to speak up and say, okay, I think this we should see it as the same thing. It's my right to use certain substances, and I have the right to have access to safe substances, to get information, to get education, and I want my children to be educated in a good way. But it's quite far, and if you have any suggestions how we can move forward from that point, because it might be a way of going forward, because I shared the idea that we have been very innovative in the 90s and be able to do things because there's an emergency with the HIV and the overdose and so on, and now nothing is moving. It's like we forgot at that time. We were so much focused on this HIV and open scenes that we forgot to talk about the regulation. And which we all felt, I think, that was the essential point behind it. And now we are in a new situation. We think we might start some legal regulation of cannabis with these pilot studies, but I think there's a risk, because we're going to lose another 20 years instead of going straight away to talk about it as something that is we could apply the same thing for other drugs and cannabis. You know, I'm a bit scared that, you know, it's again we do something which is seen as emergency, and then we don't go further and we block ourselves. That's I'm afraid of that.
Sorry. No, please.
Just what my understanding or my reading of this policy reform thing in Switzerland is that we are a good country for policy reform, really a very nice one. That's why we could do all these things in the 1980s and 1990s, because of the political system, because of many things, because we're a liberal country and all this. So many people in the world would love to have the things we have here in Switzerland. Now, what has happened is that at the end of this period where we invented or we implemented the heroin prescription, drug consumption room, all these things, we wanted to go the step further. And we had this drug law reform that came from the government, this proposal, which had a lot in it. It had not only the whole harm reduction package, it had the decriminalization of all drug use, and it had a legal cannabis market and the legalization of cannabis in it. And it came, and we all hoped that we would go this step further, and it came in a very bad political moment. Okay? There was the Conservative Party going up very rapidly. There were other things on the table, and then it was killed in the parliament. But it was killed not very clearly. It was killed, but it was killed. And then just afterwards, we had this thing with the ballot initiative on cannabis legalization, which was also, you know, put in competition with the Four Pillars policy, and you know, those things. And that's the price to pay in Switzerland. If you miss parliament and you miss the population, then you have 10 years where you suffer. Yeah. You have to say during 10 years nothing is going to happen because your policy proposal hasn't been going through. Now the window is opening again in front of us. So the possibility to do the change is, again, it's like a reset that is happening currently. Now, this time we should miss it. And this is the good question, is how are we going to do it right this time? What I miss very much is that the question of the cannabis legalization nowadays is not the same as 20 years ago. Now we have an industry of cannabis who is knocking at the door and is just waiting to take, you know, the space and all this. So it's more complicated than it was 20 years ago. There are other players in the field which we have to handle. But I think the door is just opening in front of us for drug policy reform.
I think the point is that this is bigger than cannabis, right? And one of the things that has happened in the U.S. with cannabis, the reason why cannabis is becoming legal in the United States is because of industry. People have figured out how to make money. Law enforcement has figured out how to make money. The security that you need to have a cannabis dispensary, they are okay. And there are a number of other people making money. But the point here is that cannabis users or people who've advocated for cannabis oftentimes see that drug as different from cocaine or see that different from heroin, and they are equally oppressive when it comes to things like cocaine and heroin. And so for us, we have to continue to focus on the larger issue. The larger issue here for me is, when I think I've taken to reading these constitutions around the world, and the Swiss Constitution, you all guarantee this issue of personal liberty, as Barbara and I have discussed. And your constitution also guarantees this sort of mental integrity, meaning that you can control your internal world, and that includes with psychoactive drugs. And so it provides a space for you to say, to your politicians, to your country, are you going to live up to the ideals that you espouse? And if you live up to those ideals, that means that people should have the right to alter their consciousness. Of course, people will say, well, what if they harm someone? Well, you have laws in place for people who harm people. I mean, you can't harm people in the pursuit of your liberty or your rights. That's against the law. And so this is an opportunity for all of us to raise this issue to the general public. It's like, are you the people that you say you are? And if you're not, well, change your constitutions and say that you don't believe in liberty like you say you do. It's quite simple.
It's logical and simple, and still even the rightist parties who are very much for liberalism don't come along at all. They just refuse to follow this logic, and not just for moral reasons, because they think it's bad to have these substances.
For illegal drugs?
Yeah,
what's
for
currently
illegal drugs. And that's something that's very difficult to change, I think.
Of course it's difficult, but that's why we do the work. It was difficult to change it for things like cannabis, but it happened, and so that's why it's largely up to us too to put pressure on politicians, and when people are hypocrites, it's up to us to call people out because people are suffering as a result of their hypocrisy. And so I guess the question is, are we the people that we claim to be?
So we were talking about the market regulation as an alternative to the war on drug paradigm that we are living under. So maybe we can go a bit further on this topic and talk about more precise action that could be taken in the future. There are measures that could be done, like drug testing is something that was a little bit more present in the last few years. There are talks, I think, in the US as well about fentanyl testing at least, but there is maybe no broad discussion about drug testings. But maybe let's talk more broadly about this issue, the small steps we could take, but also the more systematic changes that could happen. What do you see, maybe Carl, as the first steps, or as the broad changes having to take place to have drug policies that respect human rights and people?
Yeah, so I've been thinking about this issue a lot. I recently published a book called Drug Use for Grown-Ups, Chasing Liberty in the Land of Fear. Chasing Liberty in the Land of Fear is what I've really been thinking about. I've been thinking about it because having worked in this field for 30 years and working on incremental sort of progress, that just small steps, and thinking that I was doing something, and really it's not much. Well, I'll tell you about incrementalism in my mind. So my ancestors were enslaved in the US, and so incremental steps to abolish slavery were things like, we will make sure the conditions under which we house enslaved people are improved. And that's an incremental step. Meanwhile, people are still in bondage, right? And so as I think about our topic, drug users, we say things like, we'll make sure that they have supervised injection facilities or consumption facilities. We won't make sure they have houses, but we'll make sure they have these facilities when in fact they need houses. And then we won't say that we'll make sure that they have substances that are pure and they don't have to worry about tainted substances. And so we make these incremental steps without actually liberating people as we claim to do. And so I have decided that I am no longer working on those incremental steps, because I think of my own ancestors who were enslaved and people making incremental steps and saying, okay, be quiet, you're okay for a while. And I don't want to do that to people who are suffering. And so what I've done is, I'm a university professor, so when I teach my courses, I've now changed the way I teach. I teach about the Constitution and the Declaration of Independence first, so people understand that we are not the people that we say we are. And whenever I'm on television programs, or I write, or I'm in a scientific space audience, I always bring up this issue. Because everyone says that their heroes are people like in our country, they say my heroes are people like Martin Luther King Jr., who was working on liberating people. And they would say that I would be like that person if I was around in his time. Well, this is the issue. If those people are your heroes, why aren't you behaving like that? And so that's how I'm trying to behave. And that's how I try to encourage people to behave. And there's a lot, and people say, well, there's risk in taking this stance. There were risks to people like Martin Luther King, of course. He went to prison. There's always risk when you're fighting for freedom, when you're fighting to liberate people. There are always risks. If you don't think there are risks, then you're in the wrong profession.
Thanks a lot for this insight. That's something I think we can learn from you. Maybe be more bold and talk about real systematic change as well.
I'm not bold. I'm not bold. People are suffering. And I can't stand aside and knowing that it's needless. It's based on our misconception and our lack of will. And so I'm not brave. It's the people who are suffering who are brave.
Thank you, Carl. And I think you're very courageous, you know, for standing up and writing your book, which I encourage everybody to read.
That means a lot to me because, you know, I learned a lot from you, of course.
Thanks. But I was thinking, you know, what could I do and what could I improve and what can we help to change? And I realized that there is a dilemma within me, you know, how to go forward. I'm a doctor, I'm not a politician. And I'm always sort of blocked by this, that I don't know exactly what would be the next step. Because I've learned that, okay, you know what you want, but then they will say, also with the Federal Commission, you know, say, no, maybe not that yet, you know, because we need the good political situation. Okay, so that's one thing, you know, this difficulty on, especially within the Swiss systems, as Frank talked about, that you choose the right moment, and I find that as a doctor it's very difficult, you know, to understand exactly what's behind that. So that's one thing. The second thing. I mean, I'm quite convinced that we should legally regulate substances since years. You know, when you work in this field, you realize more and more this is the basic of our problems. But when you, as a doctor, go speak out about that, it's I put myself in like a defensive position, like I'm not encouraged, you know, because I think people will think I encourage drug use, which is not the case. I have a neutral position. But I know people will use substances, people will do the things that we don't advise to them as a doctor. If I tell my patients that, you know, maybe for their, you know, the health problems, it would be better to start exercising and eat less sugar and eat less fat, I can advise and can try to accompany with the way I've learned to do that, you know, in their change. But most people will not do that. So, and if I can talk to people about drugs, the only thing I can do is give advice and say, okay, well, these are the risks and these are the advantages. But the major thing is that I don't know what the substance is. So but it's difficult when you talk about drugs that are forbidden, that you are put in this position, oh, she talks about legal regulation. It's like encouraging young people to use drugs. And I find that very difficult to find the right tone. But it's that's the thing, how we talk in the media in general, you know, and how we should react. You know, if you look how we talk now about the crack use in one part of Geneva, it's so horrible. It's again the bad crack, the bad thing, the bad deal, the things. It's dramatic. It's fear mongering. It's everything we knew before. Nothing changes, and you're just observing and saying, what should I do? And should I go? And we try to be neutral and say it's not a drug, it's maybe the circumstances, the social circumstances, the fact that you don't sleep. You can provide neutral information, but I feel that it's very difficult to find the right tone. And maybe I should still be more proactive and always reacting on these things when I read something that I don't agree, and stand up more. But it's delicate. It's delicate.
Well, I think that's my experience now over the years, 25 years. When we as experts stand up, that's my feeling. We are not taken seriously, right? So I think we tell the same stories now for decades, and we know that we are right, but still nobody believes us. So I think we have to find coalitions. We have to work with other fields and get a broader range of voices sort of standing up for this. Because, so that's why I think about people who use substances who should also join us, or judges or whatever, or legal system. I think we should think about that to find a broader coalition of people, experts in other fields who help and support us, because I don't think that we get any further that way.
I can tell you of my own little strategy, which is, it's not very brave, but I try to apply it, which is, as a researcher, is to shed light always on what is not seen. So try to have a study on the repression that towards drug users and document it in as neutrally as possible. That's one part. Or do something on the drug market, which nobody had done before, and just show the simple and bold reality. Or do a drug checking thing to show that there's normality in drug use, or one of these strange pilot projects, cannabis pilot projects, we are going to do it, show it all the time. That's part one of the method. Part two of the method, bring people together and show them that all the time. Never do something without being sure that you have a police officer, prosecutor around you who is also listening to what you do there. Bring them in, you know, discuss with them, because that's Switzerland. In Switzerland we talk together. That's the basics of this country. It might be very different in the US, but here it's the rule, and that's how you solve problems in Switzerland. And move it, and move it. And you see sometimes the ideas change slowly, but it takes time. And then sometimes you have a backlash like we had 10 or 15 years ago, and then you need to start it all over again. But that's how Switzerland works. And the end goal is the one we have put in the report of the Federal Commission, the previous Federal Commission, is get rid of the drug law. Get rid of it. We don't want a drug law, a narcotic law anymore. These things have too much history in there. They have too much problems, basic problems in there, that you should get rid of them and find other ways to regulate even the most dangerous drugs, but not special narcotics law. We should get rid of. That's the final goal.
There's some progress. I think overall, but it's so slow. I think that maybe that's a frustrating thing. You know, we know where we want to go. There's some movement in different countries, and I think there's more and more conscious on these issues. And maybe the only thing we can do is just continue, like you do, small little things, and to move the ideas we have about drugs and what should be forbidden and how we deal with things.
I'm not feeling comfortable with it, I must admit, because as you say, the incremental progress is not really what I think is needed. Thinking back, if we had legalized heroin in the 70s, we wouldn't have the impact we see now. We wouldn't have the people who are so
Thilo, I'm glad you said
affected.
I'm so glad you said this, because I came here and learned from Barbara, from you, and it's because of you all that I have this position. So it's a very interesting thing to listen now to you, because it's you who radicalized me. and so it's very, very interesting listening to the Swiss now. And so now that's a challenge, right? It's good because you are the ones who have led, and you don't want to be outdone by an American. So you have to continue to lead.
We can learn from each other, and I think there's luckily enough there are other movements. I like the Global Commission on Drugs. It was doing a very important, back lobbying work. I mean, everybody has this little place. So I tend to be quite positive. I think that there's some change ongoing, and And they also finally talk about the legal regulation. They you know, end of the prohibition is the last report. So, which it didn't dare to talk about 10 years ago. And it was only about, you know, trying to show the impact of the war on drugs on people, on access to treatment, on access to pain treatment, on access to everything. And now they move forward, and I hope this is picked up somewhere. But it's a long way, because it's okay. We are so linked to these international regulations. I think that's the way. It's the most important issue now. You know, how to change local regulation or national regulation, but we're so blocked by these international regulations. I don't see how we get, you know, a complete change very soon. But and not before I'm retired.
Well, one of the things we have probably to free ourselves from is these whole changes in the Swiss drug policy we made in the 80s and 90s was with the idea that people who are using the drugs are sick person and they need help. They are not criminals, but sick person. Yeah. And this logic has problems in it.
Yes.
And we have at one point, it has problems in it and it brings problems.
Yes.
Yeah. And we have at one point to get out of this logic, which was very useful, which was very good for these people at that time. But we have to find a way out of this, because there are many people who still think that is the good answer. And think that, including that the good public health approach is that. But it was not just a good public health, it was a good public health response to a very bad situation. But it's not a good public health response. And there's a lot of work still to be done to explain that if you want to have a good response to the drug issue, it's not just drug consumption or prescription. It's another approach to drugs.
Absolutely.
And that's a big job. That's our big job now.
And yeah, we need to keep on discussing and advancing in this direction. I think exchanging between each other for many, I hope as little time as possible, but there is a lot of work to be done. Thanks a lot for this discussion. I think we have to finish it about here. I'm sure we could keep on talking for hours, but now we have to act and do stuff. Thanks a lot, guys. Thanks a lot for these discussions.
Thank you.
Thank you.
Thank you, Romain.
Thank you very much. Good job.